my name is Lauren Clark. I'm doing this instead of Shannon, which is why I'm a little iffy on the technology today. But just real quickly, I'm a graduate student at USC, and I am going to present Dr. Boles, who is a medical geneticist that works in personalized medicine with mitochondrial diseases as well as autism spectrum disorder. And I will provide you all with a longer introduction of him in a follow-up email to this, but now we can get into his presentation, I believe.
Okay. Well, I wear many different hats. I'm a clinician. I have a private practice in Pasadena, California, as well as a telemedicine practice and that works across the nation, particularly in terms of helping physicians and other healthcare providers understand DNA diagnostics and what does this sequence information really mean that they got back. I also do some direct telemedicine. But I was in academia for over 20 years. I was faculty at USC and a medical geneticist there based at Children's Hospital Los Angeles. I left academia 5 years ago to go into the private sector because I felt that academia was going too slow in developing new sequencing assays and interpretations and formatting. Everything pretty much changed with personalized medicine, and that I wanted to get into the private sector so that we can move things along quicker. I was also upset about the situation that as people in academia like myself moved the needle forward, that we were just increasing dramatically and continuously the difference between what could be done and what is being done. So I hope to change that by making the latest in science and technology available to the average patient. In terms of disclosures, I'm not sure if you heard this before or not, is personalized medicine is an N of 1. All treatments are off-label in personalized medicine because there's no studies you can do. There's only one person that matters, and that's the patient. And you have their individualized genetics and their individualized understanding of their disease phenotype. Also in pediatrics in general, almost everything is off-label because drugs are not tested in children. They rarely are. And even if they were tested in children, nutrients, dietary supplements, which are a large part of what I do, are basically, they're open. You cannot patent them, so no company is interested in spending the hundreds of millions of dollars that it takes to do a study, and so they're not FDA approved because in the absence of double-blind placebo-controlled studies. In terms of conflict of interest, I mentioned I am the Chief Medical and Scientific Officer of NeuroNeeds, which does provide some nutritional-based treatments for autism and other neurodevelopmental disorders. And the genetics talk I'm giving you right now has no conflict of interest. I do provide interpretation services as a physician for genetic services, but in terms of the NeuroNeeds, I'll clearly mark where there is a potential conflict of interest at the very end of the talk. So the first patient that I want to talk about doesn't have a neurodevelopmental disorder. First of all, let me mention neurodevelopmental disorders can include intellectual disability, the new name for mental retardation. It can include autism, epilepsy, ADHD, learning disabilities, and of course, there's a lot more of them. Many of these slides are designed for autism because that's where I'm usually asked to speak about, but in almost no cases do these slides only pertain to autism. They really are for any neurodevelopmental disorder. Excuse my, I have rabbits here who are throwing their dinner plate around telling me they want to eat, so there may be some background noise. Peyton here is neurotypical. She does not have any neurodevelopmental disorder. She had cyclic vomiting syndrome from ages 1 to 10. This is a really horrible condition, which is, by the way, very common or not uncommon at all in patients with neurodevelopmental conditions, in which you have nausea and vomiting and lethargy in cycles. So the cycles may occur every 2 weeks or every 2 months, every month, or they may occur apparently at random or at times of stress. But the cycles are very stereotypical, meaning that each cycle is very similar to every other one or every episode. She had that until age 10, and then it went into migraine, which is 24/7, 365. She had multiple admissions for bowel cleanouts for very severe constipation, obstipation, chronic pain throughout her body. But her major problem was chronic fatigue syndrome. She was so fatigued that if she were to get out of bed, go downstairs to eat breakfast, that for the rest of the day she would be bedridden. That would exceed what she can do in a day. That she was completely disabled from that. We did DNA sequencing on her and found that there was a polymorphism, that's a variant, which is not extremely rare, in the TRAP1 gene. In fact, this variant is seen in 1% of the general population. Now, to put that into context, the average individual has about 3,000 variants that are seen at 1% or less in the population. So that was just one of thousands of other variants that she had. The reason why I took a hard look at this variant was because I had two other patients that had very similar manifestations that had the same variant. And also is because this variant encodes for a chaperone. The protein is a chaperone which protects proteins in the mitochondria from oxidative stress. In fact, this is the main chaperone in the mitochondria to protect proteins against oxidative stress. The other patients also had GI problems, fatigue, and pain. Using the entire computer system of Georgia Tech with collaborators there, we were able to look at, in 3 dimensions, the binding site for ATP on the TRAP1 molecule. You can see in the lower right-hand corner there is a little cartoon. The pink one is one molecule of TRAP1, and then the silver one is, or the white one's another molecule of TRAP1. It's a homodimer, means that there are 2 identical protein sequences which join together to make the functional protein. The green that you see down below, there's 2 of them, that's ATP, the currency of energy. So what TRAP1 does is it looks sort of like a claw. You can see at the top, it sort of looks like a claw. It opens up and it grabs proteins and holds them tight, and it uses ATP, to the energy of that, to do so. And in holding the protein tight, it keeps it from denaturing. In other words, from cooking in a situation of high oxidative stress. Looking again, using the computer system, we looked at every single molecule, that every drug, every nutraceutical, everything that is known to exist, and then in silico, put it into the binding site of the mutant molecule. By the way, the mutation in this protein, the changed amino acid, touches ATP directly. So we wanted to see in the ATP binding site something that would bind tightly to the mutant molecule, to the damaged protein molecule, but not affect the undamaged one, because you need TRAP1. The idea was to destroy the mutant protein because it's doing something nasty. And the computer predicted that Chitrol would do that. Chitrol organocitron is a known, it's a drug that I've used many times before in cyclic vomiting syndrome. In fact, it's used for chemotherapy-induced nausea and vomiting. But it's not chemo. It's used to prevent the nausea and vomiting to chemo. We gave her the Chitrol, and her manifestations essentially all resolved. She went to school half-time. She still has some fatigue, but she's able to go to school half-time and is essentially pain-free and had no more GI problems in terms of no more bowel cleanouts any longer. So what does this have to do with the talk about neurodevelopmental disorders? Well, I had been treating autism, particularly with a mitochondrial cocktail now for 25 years, but that was just one of the many things I did. One of the main reasons why I got into autism in terms of the research and in specializing that was a lot of my patients with cyclic vomiting syndrome and other weird types of migraine, their brothers had autism. In fact, it was a half to a third of them had it. I know autism is very common. It's as common as up to 2% of boys have it, but I mean, that was kind of ridiculous. So I realized that it was some of it was the same genetics. So I took Carter was my test case, and after explaining, all the situation to the parents, informed consent about the unknowns of that. Carter, who had exactly the same variant, the 253 valine variant in the TRAP1 gene, had pretty much uncomplicated autism. I mean, as much as you can ever have uncomplicated autism, everyone has something to it. Many cases of autism have regression, about a third of them or so. Sometimes it's due to vaccines, or at least associated at the time of vaccines. Sometimes it is associated with a viral illness. Sometimes it's associated with surgery or anesthesia. Sometimes no one can figure out what the association is. But he was a very severely autistic kid in terms of his behavioral problems, and so he was given Kytril, and he improved actually quite dramatically. Some of the things are in the slides in which he got better at. The asterisks are ones in which he was taken off of Kytril, got worse, and put back on again and got better again. So so that they were noticed to be associated with quite strongly with Kytril therapy. Now, Carter was unable to go to a restaurant. The parents wouldn't even think about going because he would just run under the tables and make animal sounds and whatever, and there was just no way that they could do that. But on Kytril, he was focused enough that he would actually eat his dinner and be quite well behaved. So it really made a big difference. As you can imagine, this is not considered on label by any means whatsoever. And insurance companies, balked at this and said, well, this is not an appropriate use of the drug. This is not, there's no literature behind this. Of course, this is the first one ever. And so they denied treatment. And at another time, the parents had to pay for it. It's an expensive drug. And they later did pay for it. At another time, there was a nationwide shortage of Kytril, and another time a pharmacy ran out. On 4 separate occasions I'm aware of is that Carter ran out of that he was off the drug, and each time he got worse and he got better each time. And it's also dose specific. We increased the dose a couple times and the improvement continued. So I'm very sure about the association here. One of the things that this shows, other than the fact that that there are common variants which can predispose towards autism, and if you identify them, you might be able to treat it, is that the genes that predispose towards autism often predispose towards multiple other conditions. They often are neurological, but not always. The genes that are involved in autism are really the genes that make proteins that are necessary to build a brain and operate a brain. The same genes also predispose towards depression, schizophrenia, migraine, seizures disorder, intellectual disability, and I can go on and on with that. Why does one patient get one and then problems such as autism, and another one may get cyclic vomiting syndrome and GI issues? Well, that depends on the other 23,000 genes and the environment. Next patient to go over is Kelly. She certainly is autistic, but it's part of a much more complicated situation. First of all, to discuss her autism, she's intellectually, she's normal to advanced. This is her artwork in the upper right-hand corner there. In fact, my office is decorated with a lot of her artwork. And but she does not speak to anybody except for her mother. She speaks completely normal, but she will not speak to anybody. She has a computer and she uses Siri's voice on the computer to speak. She will do full sentences, full paragraphs on there. Very witty answers, and her questions are excellent. She's totally and completely understands everything that we're discussing at the visit. But she not only will not speak to anybody, but except for a few doctors that she trusts, unfortunately that included me, that she would not talk to anybody. But that wasn't the reason that she came to see me, and that was not the main issue with her. The main issues with her is that she had continuous migraine, again, like the last patient, 24/7, 365. That was her main issue. She also had severe chronic fatigue syndrome, bowel dysmotility, dysautonomia, depression, anxiety. And so the last patients that I've showed you about, they were two separate patients, one with functional disease, fatigue, pain, GI, and another one with autism. This one has both, and that's not uncommon at all that I see. Biochemical testing revealed signs of a mitochondrial disorder, and then her physical manifestations, the dysmotility, fatigue, and pain, improved quite a bit on a mitochondrial cocktail, and those are the parts of the mitochondrial cocktail that specifically that Kelly was on and improved on at the bottom of the slide there. Now, when we did the DNA on her, I found two mutations in the glutamase gene. At the very far right of that little cartoon is the arrow goes from glutamine, which is an amino acid, to glutamate, another amino acid, and that's glutamase. There are more than one glutamase enzymes, and this is glutamase 2 that had the mutation. So why would, in two mutations, because one's from the mother, one's from the father, it's autosomal recessive disease, are most enzyme abnormalities. So why would glutamase cause autism and functional disease? Glutamine and glutamate are in a very large number of metabolic pathways, and they're neurotransmitters, and they're involved in a lot of different things. But after taking a look at all of the labs and thinking about it, I figured maybe it's because there's not enough alpha-ketoglutarate in the Krebs cycle, because glutamate goes to alpha-ketoglutarate in the Krebs cycle there. That's the little alpha sign Kg. And so alpha-ketoglutarate was not one of the parts of the mitochondrial cocktail that is normally given. In fact, I would say that there's probably 40 different parts of the mitochondrial cocktail that would be given before alpha-ketoglutarate would be. But I gave her alpha-ketoglutarate in the first dose. You can see the email at the bottom the mother sent to me. That's the actual email copied and pasted on that. We since doubled alpha-ketoglutarate 3 different times, so she's now on 8 times the dose. And her autism has improved quite a bit on that. She still uses Siri's voice, but now she goes to community centers and where she discusses her, shows her artwork, and she goes to art shows. So it has, figuring out the problem in her has made a difference. Now, these two cases, what they have in similar is that they involve mitochondrial metabolism. One of them was a chaperone in the mitochondria, which protects mitochondrial proteins against damage. And another one is an enzyme in the Krebs cycle. So very different aspects of mitochondrial metabolism, but they have that in common. Mitochondrial disease, and both of these patients can be considered to have mitochondrial disease, is not very common in autism. It's maybe 1 in 10, as studies have shown. Again, I'm talking about autism, but I'm also seeing it not uncommon in intellectual disability, and particularly in epilepsy. I see it pretty common. I suspect it's more than 10%. But the 10% is really just the tip of the iceberg. There's a large number, a much higher number of people with neurodevelopmental disorders, and this includes autism, intellectual disability, particularly seizure disorders, also ADHD and learning disabilities, that have mitochondrial dysfunction. But the underlying genetics is not that of a mitochondrial disorder, at least not a primary mitochondrial disorder. The abnormality is somewhere else, and mitochondrial dysfunction is a secondary problem, but it does make a big difference in the pathophysiology. Doctors Fry, Richard Fry, and Dan Rosignol have written a lot of papers together. If you're interested, just put Fry and Rosignol in PubMed together and see the papers that they've written. They've done a lot of work in the laboratory, and about 50 to 80% of individuals on the autistic spectrum have mitochondrial dysfunction. And I think that, in my opinion, that might actually be an underestimate because of the way mitochondrial dysfunction is mentioned. Does everybody with autism have mitochondrial disorder? Definitely not. Is mitochondrial dysfunction the cause of most people with autism? No. Autism is much more complicated than, say, there's only one pathway. In autism, as well as in epilepsy, it's often polygenic. There are multiple genes involved in multiple pathways, and the phenotype or the clinical manifestations, disease, is based upon the the totality, all of the genes together, and of course, all the environment together. Okay, so I mean, what do I mean by mitochondrial cocktail? Mitochondrial cocktail or nutritional support, in particular dietary supplementation for mitochondrial dysfunction. It's not very well defined, but and you ask different mitochondrial experts, they'll give you different ones. But there's maybe 10 core mitochondrial cocktail elements, and there's maybe 30 or more that people will identify that falls into that. Mitochondrial cocktail boosts cellular energy, but it also detoxifies reactive oxygen species. And another question I keep getting up when I go to autism conferences is, well, my child has not been proven to have mitochondrial dysfunction. Do I have to test for it? And I said, I used to test everybody, but since almost everybody with autism and a lot of people with epilepsy have mitochondrial dysfunction, I don't test for it anymore. I've had people test negative that have gotten better on cocktail. So, and it's not going to harm anybody. It gives you more energy. In fact, the #1 reason for the mitochondrial cocktail is probably aging. Aging is the most common mitochondrial disorder. Okay, so to step back again, I mean, this technology sometimes can look magical, and I show this slide to show you as a transition to how the technology works, and also because my daughter loves her picture show. This is the machine that does it. The Human Genome Project took 10 years, spent billions of dollars, and finally was able to sequence all of the DNA of a single person. This machine here, the HiSeq 4000, will do it in an hour. And it will do it for $1,000. It's really quite remarkable what we can do now compared to what we could do even a few years ago. When we were doing gene panels, and panels were going from tens of genes to hundreds of genes and then to thousands of genes. Now we routinely sequence all 23,000 genes, which is called exome. And in many cases, and this is what I'll recommend, we sequence all the DNA in between that can be sequenced, and that's called genome. And this machine can do a genome, or all 3 billion nucleotides in an hour. Okay, so when you get that, you get tens of thousands of variants in the average person. On an exome, there's about 30,000 variants that shows up on my computer for me to interpret every time that I look at someone's exome. And in a genome, it's about the same number because we don't understand most of it in between. So how do you distinguish between all these variants? What is it that's done? Well, first of all, I want to talk about the testing that's necessary. A variant can be small or it can be large. The smallest variants are 1 base pair. Sometimes they're called SNPs. SNPs generally means single nucleotide polymorphism. So those are more common single base pair changes. And they can be large. I mean, Down syndrome is tens of millions of base pairs duplicated, the entire chromosome 21. So it can be anywhere from 1 to tens of thousands to tens of millions of base pairs, and anywhere in between. The vast majority of changes in our genome are single base pair. So it's very heavily weighed towards the left side of that slide. The reason to show this slide is it's different technologies. Sequencing, particularly WES, whole exome sequencing, that sequence all the genes, will look for things that are small, typically up to about 50 base pairs, 1 to 50, on a good exome analysis. Microarray, or chromosomal microarray, CMA, took over after karyotyping our chromosomes, and it looks for things that are large. It can go down to about 500 base pairs in gene-rich areas. So you can see, first of all, that these do not overlap. If you're doing exome sequencing, you are not looking for large changes. And if you are doing microarray, you are not looking for small changes. And there's a little gap in between in which you can't find by either sequencing or microarray. Fortunately now, whole genome sequencing, in which you look for everything, can now do the whole thing. It can do the entire spectrum from 1 to tens of millions and everything in between with no gap. So if you're doing it I'd say the old-fashioned way, what was done a couple of years ago, and what most academic centers still do today, is they'll look for small mutations by sequencing, exome or whole exome sequencing. They'll look for large mutations by microarray, a chromosomal microarray. But that is changing to whole genome, pretty much. Okay, the larger mutations. Not long ago, large mutations were done by karyotyping, a chromosome analysis, and that would only do, then you were looking at millions of genes, maybe 100,000 genes. And then they could do a CMA, chromosomal microarray, to look for changes, a copy number variant, CNV. Copy number variant can be too little or too much. So a deletion, if you have, normally you have 2 copies, a deletion would have, you would have a single copy, and a duplication, you'd have 3 copies because one of the parental copies was duplicated. So the larger copy number variants, the ones that could be considered chromosomal abnormalities that you might find on a stereo chromosome, typically they would involve a very large number of genes, like at least 25, 50 at the very smallest, and often much larger than that. You would expect to see intellectual disability, other neurological problems, maybe seizures, hypotonia, growth anomalies, usually small, sometimes large, birth defects, congenital anomalies, and dysmorphic features, funny looking individuals, which are really small little birth defects of the face. But that's really not the case anymore, because instead of looking at 50 genes at a time, a chromosomal microarray can now look at a single exon in a gene. A gene may have 30 exons or more. And this, with chromosomal microarray technology, you can now find a deletion or a duplication of a single exon. And those are not going to have these kind of large CNV findings. So you will not find it in the box. So sometimes doctors will say, well, it doesn't look chromosomal, they're normal intelligence, normal size, no birth defects. So this is unlikely to be anything we need to do with chromosomal microarray, and that is not true. If you just do sequencing, you're going to miss a lot. Other thing I want to show is on this slide, you see that there's the copy number variants. The top one would be chromosome 16, the P arm, which is the smallest arm, band 11.2. And that refers to the old chromosomal analysis. That would be band 11.2. There are hundreds of copy number variants that are statistically associated with autism, hundreds that are known. New ones come up every time. I stopped keeping track of them 3 years ago when it got to about 500. And 3 years ago when I made this slide, this was the number of studies that had shown an association between this particular copy number variant and autism. Now, one thing is that these same copy number variants are seen in people with intellectual disability without autism frequently. They're also seen in people with epilepsy, other types of intellectual issues below intellectual disabilities, such as ADHD, learning disabilities, etc. And they're seen in normal people. And that's what I'll show you on a slide pretty soon. They're actually pretty commonly seen in normal people. These are risk factors. They increase the risk of having disease. They do not cause disease. I'm going to show you 2 of them on here. First one, 22q11. Some people might recognize this. This is the D. George critical region, but a lot of syndromes turn out to be due to deletions in this region. And the reason to show you this is it really depends on what genes are affected. If you are missing the COMP gene, then you'll have behavioral changes, because this is the gene which breaks down catecholamines, which are like stress hormone, epinephrine, norepinephrine. If you do not delete the COMP gene, then you won't have that. If you delete the TBX1 gene, then you're likely, again, risk factor, you're likely to have cardiac problems. If you do not delete that, then you're not at risk. So it's not just the chromosomal area only tells you the neighborhood. You need to know which houses are involved to look to see what kind of problems that you might have. And so when you look at a deletion, the first question I ask is, well, exactly which genes are affected? Because that will tell you what sort of phenotype, what kind of clinical manifestations are at risk. The other thing, as I mentioned, is that these are risk factors. They don't cause disease. So they can be seen in normal individuals. I saw a child with full DiGeorge syndrome and had a really severe cardiac malformation. The child, which was recognized right after birth when the child crashed immediately, and was on life support and going to have cardiac surgery, found out that there was a deletion of 22q11, convinced the parents to have their chromosomes done, even though they said that they were completely normal and didn't understand that, and found that the father, who's completely normal and works as an engineer, has the deletion. They didn't understand, so there's a very high recurrence risk in their children. They didn't understand, how could that be? But the father had a very nasal voice, and he has a very small cleft down in his larynx that causes his voice. And that abnormalities in the airway are also very common for a deletion of one of the genes in this area. So he was completely unaffected except for that. That's what we call a form thrust. It's not unaffected, but it's almost unaffected. Basically, no clinical manifestations. So you can see anything from completely abnormal to the full syndrome and anywhere in between in one of the parents or a sibling that carries the gene, and obviously that person's children are at risk. Another thing is that I recently saw a functional disease doctor had me go through the DNA on one of his patients, and it was an 18-year-old who had autism and was known to have a diagnosis of that for years, and at about age 15 decided that he didn't want to talk very much. In the last year, he hasn't said anything at all practically. And they were trying to figure out, that's not normal in autism. You don't usually do that. But he had 22q11 deletion, and the COMP gene was missing. And when you have the COMP gene missing, that's high risk for schizophrenia. It turned out that he had schizophrenia, which is not a good diagnosis, but at least there's drugs for that. So knowing which genes are affected can make a difference. The other thing is I want to mention from that is just because it's a large copy number variant doesn't mean that it can't be treated. It's not like, oh, I don't want to know what the location on the genome is because it's not going to make a difference. It really does make a difference in many cases to know what the diagnosis is. I'm only going to go through one more, and that's because this is the last holdout. I mean, not long ago, as a geneticist, I had to spend a lot of time talking to the family, examining the child, measuring things, looking through textbooks, looking in the internet eventually when that came up, and trying to figure out what the child might have so I know what test to send out, because the tests had to go to different laboratories all over the world, very expensive, and it was time consuming to fill out all the paperwork. But now, of course, now you just do whole genome analysis and you sequence everything. Well, Angelman syndrome is the one thing that really is the holdback for genetics. If you have a deletion on 15q11.2, which affects the UBE3A gene, then you have Angelman syndrome. And Angelman syndrome causes mental retardation, autism, but the things that are different in that is absent speech, they never speak. Epilepsy, well, 1 in 3 patients with autism has epilepsy. They have an ataxia, which has been akin to that of a puppet-like gait, and bizarre laughing. In fact, sometimes they have seizures or gelastic seizures in which the seizure is continued laughing. The ones that have large deletions will also delete a pigment gene and will be hypopigmented, but the smaller deletions that only include the UBE3A will not have hypopigmentation. Most cases of Angelman are not deletions on chromosome 15. They are imprinting errors, which is one of the very few places that epigenetics is clinically relevant. The gene has been turned off because of an epigenetic abnormality. It's imprinted wrong. And the gene is there, it's just been turned off by methylation, and you need to do methylation testing or imprinting testing for Angelman syndrome to find it, which you wouldn't do if you weren't looking for that. It won't be found on whole genome analysis. So that's one situation that if you have a patient that fits this, you can also send off Angelman. Okay, here's that graph again about the variance. I was showing you the horizontal axis before between one base pair and millions of base pairs. Now I'm looking at the vertical axis. The ones at the bottom are common, many people. The most common variant, of course, would be 50%, because when you get to 50.1%, then the variance is the 49.9%. And the rarest a variant could be is never seen before. In fact, if it could be a de novo mutation in which the parents don't even have it. It was a new mutation occurring in that individual. So variants, one of the things we look at is prevalence. How common is the variant in different individuals of the population, including in that particular population? Because if the individual comes from a population that is not very numerous, at least not very numerous in those people that have been sequenced, you really need to know how common it is in that population, not the population necessarily that on the databases. So what this slide is showing you is that if it's very rare, it certainly can be the cause of disease. And what I mean by the cause of disease is not the only thing, because there really isn't any such thing as a monogenic disorder. There's always modification by the rest of the genetics and the environment. But it can be such a large part of the factor involved in creating the disease that you can say that it really is the cause of the disease. You can use the causal word that we don't really use very much. But almost everything else is risk factor. And risk factors can be never seen before as well. Most of the variants that we're talking about are not variants that cause disease, but are risk factors that contribute towards disease. And that really makes a big difference in terms of treatment, because sometimes you can't find the causal factor because sometimes there isn't any. A lot of people have disease based upon the interaction of many genetic factors with environmental factors and not a dominant mutation. Okay, well, variants can be de novo or inherited. De novo is just Latin for new. A de novo variant is not present in either parent, at least not in the tissue that was looked at, which is usually blood. Even when you're looking at saliva, you're mostly sequencing blood cells from saliva. A de novo variant is often, but not necessarily, the main cause of disease. The word causal is something that usually is used or is appropriate in situations like that. About 1/3 of autism patients, and maybe even slightly more than that of severe epilepsy patients, have de novo variants. So it's important to look for them. Individuals with de novo variants typically are lower functioning. So in individuals, say with IQs below 30, it's pretty common to find that. In individuals with IQs higher than 100, you can see them, but they're quite rare. And they have a low inheritance risk. Theoretically, the inheritance risk should be 0 because it was a new mutation that occurred only in that child. But there's a possibility that the mutation actually occurred in the gonad, in the sperm, or in the eggs, and there may be other germ cells in there that are also affected. So we usually say about 1% or so, because I have seen recurrence before, but it is very rare. Inherited variants usually means the variant came from one parent. Occasionally it came from both parents. Inherited variants can be inherited from a parent with the mutation that has the disease, and it could be causal, but usually it's inherited from a parent. Usually it's inherited from a parent that doesn't have the disease, either completely normal or with a form Frust phenotype, like I mentioned, that engineer that had the nasal voice. It has so little of it to be considered to be clinically normal. Certainly it can be somebody that has the full disease, epilepsy, autism, intellectual disability, or it can be somebody with another disorder. ADHD and autism run in the same families because the same gene is predisposed towards both. And autism, not uncommonly, has a parent that has ADHD. One of the interesting form Frusts of autism is one of the main things that autism is it's turning inward of the mind. If your mind turns too inward, you really can't do social communication, and that's what we call autism. But if the mind turns in to some degree, then you're just not as social and your mind is more focused. People that have very mild phenotypes or form thrusts often are more successful in their careers than so-called neurotypical people. Name a billionaire, and it's a good chance that that billionaire has a mild form of an autistic spectrum disorder or ADHD. It allows you to become very creative and to focus inward, and to do very well in higher education as well as in your chosen career. The next case study I want to show about is another complicated one. Zach is full autism. He was diagnosed at 18 months with a loss of milestones with no known triggers. He also has cyclic vomiting syndrome, or he had it, bowel dysmotility, headache, muscle pain, exercise intolerance. All of that we've discussed before. Rhabdomyolysis we hadn't. That's when the muscles break down. But he had complex regional pain syndrome. His right foot was purple and swollen and exquisitely painful and tender. He couldn't wear a sock. If you just touch it, he would scream. He was that way for a year and a half on multiple narcotics at high dose despite severe pain. And he had multiple MRIs. They didn't show anything. He was put on mitochondrial cocktail and amitriptyline, which works for neuropathic pain. His rhabdomyolysis, his cyclic vomiting, his complex regional pain syndrome, they all went away completely. He was able to not only walk and run, but also to climb, jumble gym, and totally off narcotics. He used to have more than 25 admissions per year, and that went down to 2 per year, both of them for bowel problems. And then later we found that genetic testing revealed an underlying issue. And what I found unsuspectedly was in the CHAT gene, which is the gene that encodes the enzyme choline O-acetyltransferase. It is the enzyme which synthesizes acetylcholine, which is a major neurotransmitter in the brain and in the peripheral nervous system. Acetylcholine is made from choline and acetyl-CoA in neurons that make it, cholinergic neurons. I've seen many other patients with this as well. They typically have functional disease, pain, fatigue, GI, but they get episodic mental status changes, as you'd expect with a cholinergic deficiency. They get very severe POTS dysautonomia, again, because the pre and post synaptic neurotransmitter in the autonomic nervous system, and particularly in the parasympathetic nervous system, is acetylcholine, and severe reactions to anticholinergic medications because they don't have enough acetylcholine. So if you block those receptors, they get even more of a problem. These patients have improved, in my experience, greatly on using inhibitors of the enzyme that breaks down acetylcholine. And I put down 2 of them there. Aricept works in the brain. It crosses a blood-brain barrier. He was given Aricept, and his expressive speech improved dramatically. In fact, the mother had emailed me that Zach was now saying full sentences. And I was thinking, oh, that's really nice. Zach has gotten better. I'm glad for that. But I could not believe that Zach, who had echolalia and would repeat what you said, and any question that you would say, he would say yes to. That even if it wasn't a yes or no question, he would be speaking in full sentences. She brought him in, and he indeed was doing that. So what I want to get across here is that finding the underlying contributing factors can be helpful, not necessarily in terms of the symptomatology, which is not core autism, but it can also help in core autism. This is an abnormality of neurotransmission, and I've mentioned before an abnormality of the mitochondria in terms of the TRAP1, in which the individual improved, and also with the Krebs cycle intermediate in Kelly. If you know the underlying problem, sometimes you can help core autism problems. Okay, Luca, he does have autism, but his seizure disorder was the main problem that he had. That was his number one issue. It came apart after a routine vaccination. He also had GI dysmotility, chronic fatigue. All further vaccinations was withheld. I'm in California. That's a major problem because of the law here says that you can't really do that. Substantial improvement on mitochondrial cocktail, and later that we did DNA sequencing. Found a variant in the sodium 1A gene. This is sometimes thought of as a Dravet gene because Dravet is a very severe type of epilepsy in which you can have mutations in sodium 1A. I see mutations in sodium 1A in all sorts of types of epilepsy and frequently in patients with autism without epilepsy. Also, sodium 1A is probably the most common genetic abnormality going through vaccine court in Washington, D.C. I'm involved in a case right now as an expert for sodium 1A. Many of those cases have gone before me as well. In my opinion, sodium 1A is a risk factor for vaccine-associated deterioration, and that it is a counterindication for vaccines. The government thinks differently, and the two of us are battling it out on that. The family withheld vaccination from the brother, who's unaffected except for hearing loss. And the brother was found not to have the variant. So this is a situation in which genetics can make a difference and make sure that a kid gets vaccinated who should be vaccinated, who is not vaccinated. I want to mention something right now. I am not an anti-vaxxer. I have 4 of my own children, and they've all been fully vaccinated. The vast majority of the patients in my practice have been vaccinated. There are a few cases like Luca here that hasn't been, and there are some in which I vaccinated on a slower schedule, but they all got vaccinated before they got to school. I'm saying that there's a small number of people that have genetic factors which served as a risk in terms of the perfect storm for vaccine-related injuries. Oftentimes, in my experience, being in vaccine court many times, usually they had a viral illness. They may have gotten the pediatrician's waiting room at the time. Often they're given acetaminophen, which binds glutathione, and so affects your ability to protect against oxidative stress. Often they had fevers, which raise energy metabolism. There are many other risk factors as well, and they happen in the age between 6 and 24 months. Usually that individuals have the highest brain metabolism per gram of brain tissue. So I think it's really the perfect storm, and I like to use genetics not as a way to not vaccinate kids, but as a way to vaccinate them because identifying the risk factors. And there's no way that with current technology we can find or that we understand all of the genetics of vaccine-related disease. But we certainly can look for what we know about. Okay, genetic testing, as technology improved and as price went down, we went from a situation in which we were looking for common mutations, just look for a single base pair, or for like an expansion in Fragile X, a known mutation, which is the lion's share of the disease, to single gene sequencing. I remember when single gene sequencing came out 20 years ago, it cost $5,000 a gene. But it was amazing that you could sequence the whole gene at that time. Then we started doing small panels like Rett syndrome. There were 2, 3, 4 genes known to cause Rett syndrome. Now there's about 10 or so. You can put those in a panel. Eventually, we made panels for autism, epilepsy, mitochondrial disorders that would be hundreds and then eventually thousands of genes. And then a few years ago, it pretty much all went to exome because it was impossible to keep up a panel, and the prices of the panels were as expensive as exome. So why do a panel that's going to be out of date even when it's launched when you can do exome for the same price? So exome is kind of the standard now in most academic centers. You do all 23,000 genes. I really think that genome is more important. It's not just genome does everything between the genes as well that you can sequence. You can't sequence some of the very highly repetitive areas. But in genome, yes, it is looking at the future. It is an investment in the future. It won't be somebody like me that in a year or 2 years from now says, okay, you've done exome, now we should do genome. We're finding more and more mutations outside of the exome, which are clinically important. But the main reason I get genome sequencing now is it's simply cheaper. If you do exome plus mitochondrial DNA plus microarray plus Fragile X, and then you add on that pharmacogenetic testing, it's a lot more money than doing genome. You can get it all from genome. So this is in alphabetical order, and this is a long time ago, so it looks more complicated now. You can see in column B, that's the gene, the name of the gene, at least the call number of the gene. In column D, it gives you the change in the amino acid. In column E, it gives you the change in the nucleotide code. Columns J through L look at it in different computer programs at it. Actually, I need to change the slide because it's far more complicated than now. We have like 3 times the number of columns. You can look in column N is how common it is in the population, that variant, the human population. Or column L is how common it is in other species to look at evolutionary conservation. If the same amino acid is all the way back to fish without any changes, it probably is an important part of the protein. But if the amino acid in every species is different, it's probably not an important part of the protein. So those aren't 100%, but they do help go through 30,000 variants and try to bring them down. We obviously look for variants that are highly conserved and are rare in the human population. And this is just the first genes in alphabetical order. These, in this patient with autism, these are the variants I thought could potentially be disease related. This is an individual with high functioning autism. In fact, this is Dr. Temple Grandin's exome. And I mean, if you've ever heard Dr. Grandin speak before, she's an incredibly good speaker. She's very funny, very witty. She is very, if you say that, you know, autism is her disease, she gets very upset, and with good reason, because autism to her is not her disease. Autism is a trait. It does give her some difficulty in social situations, but it allows her to be extremely effective in her chosen careers. Far more effective than just about anybody in that. She sees this as a trait, which gives her some negatives and far more positives. But what really bothers her is that when she stands up to give a talk, suddenly her foot will become like it's on fire, incredibly painful. It will start aching, and she gets these rashes and swelling in different parts of her body. And she's been having this for decades. In fact, she had these rashes since a small child. They were biopsied and no one can figure out what they are. Well, she has 2 known mutations for familial Mediterranean fever, which fit her phenotype completely and are treatable. Okay, this is my, just to kind of step back, I've given all the data. Now I'm going to try to integrate it together to show, you know, okay, so I've shown that you can do genetic testing and genetic testing makes a difference. What does this really mean in practical terms? How do I get it? How do I pay for it? Those sort of things. And by the way, these are some of my pet chinchillas. The little one is 4 hours old. The bigger ones are 8 days old. And they are all mutant chinchillas with different mutations, but I haven't sequenced them yet. I think they're neural crest abnormalities. But they are my pets, and they're, okay, so.
Dr. Boles, I hate to interrupt you because I think everybody is really enjoying our presentation, but it is 8:58. And I know
Okay.
that some people may have to be signing off at 9. So if you just want to give some closing remarks, and again,
Yeah.
Everybody who is still interested in seeing the end, you will all receive a copy of the full presentation and Dr. Boles' comments as well.
Okay. Prices have dropped dramatically. Insurance costs are higher than this, but costs, if you're paying for it, it's like a credit card, they have come down. We can get genome in some labs for as low as 1,800, exome for 1,000. A letter of medical necessity and using the proper coding is always important. Like epilepsy, if you have it, is better to code than autism. Don't encode anything that's behavioral or like intellectual disability. If there's something like hypotonia or something, or hypoglycemia, certainly code it. The recommendations in neurodevelopmental disorders, this is for all of them, not just autism, is to do exome plus microarray to look for small and large. Mitochondrial DNA in many labs is separate from exome. You have to order that separately. Fragile X is important, and then pharmacogenetic testing. But whole genome should cover most or all of that. The large, and then Angelman syndrome is depend on, if you think that you have it. The big question is trio versus singleton. When do you test the parents? Well, de novo variants, you really need to know the parents because it's in the child and not in the parents. That's the main reason to test the parents. So patients with intellectual disability, severe autism, and seizure disorders, any severe neurodevelopmental disorder really need trio. If it's high functioning autism, you can get away with it. ADHD, things like that, you can get away with it. The other reason to do trio would be birth defects, syndromic like things. Trio is usually double the price, but insurance pays for, actually, in my experience, for autism and epilepsy, insurance pays about 3/4 of the time if you have insurance. And they pay for trio just as much as singleton, so you might as well put that down, and if it turns out the patient is paying for it and price is an issue, you can go down to singleton, particularly if you can. Again, that your physician can determine what is right for your child and order testing. However, in my opinion, trio whole genome sequencing is the correct test in most situations. The major issue is who will interpret it. I don't have enough time to go into this in very much detail, but with CNNH, which is in the New Jersey, in the Philadelphia area, I have set up a system where we can do peer-to-peer counseling. So in all 50 states and abroad, anywhere in the world, we can suggest what DNA testing to be done. You give a paragraph on it, and I'll do the suggesting. You have to order it because the physician has to order it. I can help you to understand what the genetic test results mean. I can give you usually it's around 6-page or so summary of the findings and recommendations. And the most important thing is that it's not me as a laboratory blind to the patient. We discuss the patient beforehand. So I have a really good feel of it. I discussed the gene abnormalities that I found, or the potential abnormalities, and then we discuss to see, which ones seem to affect the patient, which ones we think are most likely, and then we can go back and forth about what the treatment options are. I put the number of states there that I'm licensed in: Arizona, California, Florida, New Jersey, Pennsylvania, South Carolina. If it's in one of those states, the family can be involved in the call. I can ask questions, they can ask questions. But considering if the family is involved, it's the practice of medicine, they have to physically be present in one of those states. Or else I'm practicing without a license. I want to be as helpful as I can while remaining out of jail. So that's sort of the goal. I've had patients that have even flown to grandma's house or drove across the border into one of those states so that they can be there when I'm talking to their doctor. It's legal, and it's a way around the licensing laws and everything. The other thing is that we can do is that you can actually go in physically into New Jersey to see the neurologists there that are involved in neurogenomics that are good at this. And I can do direct telemedicine, meaning I can be the physician that taught and does the direct, just like you came to see me in Pasadena, in those 6 states, so we can do it by telemedicine. If you're interested on there, there's the information down below. Don't have really time to go through this, but I just want to show you the percentages at the bottom. The last 17 patients we did before that we did the slide. In 16 of the 17 patients, this changed the physician's management. In 15 of the 17, there were changes in therapy that were recommended based upon the genetic changes. And you can see the numbers in which indicated additional tests and outside consultations. Half of them received a pathogenic genetic diagnosis. This is the cause of your child's disease in half of them. So I was very happy about that. So even the ones that we don't find the cause, often we find candidate variants that may or may not be involved and that they're treatable. I'm not going to go through this. This is just 7 patients and what their genetic abnormalities were. Why do this? Right therapy may be something different. Right therapy may be creatine or mitococktail. It may be many other things. It may be alpha ketoglutarate. It may not be a drug. But if you do a drug, use the right one. Not just any drug that just because it's used in that disease. Find the one that's effective for that condition. And you saw that you used Kytril, never would have been fought. And then the right dose. This is where the pharmacogenetics goes in. It talks about drug metabolism. If you're a fast metabolizer, a normal dose of the drug may not be enough. You may consider a higher dose. If you're a slow metabolizer, don't start at the usual dose. Start at a quarter of the dose or no more than half the dose because you may get a lot of side effects. A lot of people said, oh, the drug caused too many side effects. When they were a slow metabolizer, and when we decreased the dose, it works great. Many people said, oh, the drug didn't work. They were fast metabolizer. When we doubled the dose, it worked great. So it really does make a difference. I'm not going to go into this. The whole thing is that the genes don't tell you how long you're going to live and what you're going to have. They're the cards that you are playing with, but how you play your hand makes a big difference. I cannot emphasize more that understanding your genetics can make a difference in therapy. It's not just what you have and you can't do anything about it. Mitochondrial cocktail, I've mentioned that there are many components, and the top of there, I meant those are the ones that I consider to be the most important aspects of the mitochondrial cocktail. The bottom there, those are what are often, that studies have shown that these nutrients can be deficient in patients with autism. That in their hair or teeth or something like that, that shows that they're deficient. So between the two parts of the slides, there are 26 different nutrients. And so I used to actually have patients on 20, 30 different products, and it would make a big difference in many cases, but it's crazy, it's insane. And so this is where the conflict of interest goes in. I am one of the founders of NeuroNeeds, and we have a formula that all of these doctors helped me make that is based upon the literature. I don't have enough time to go over that now. Corrects dietary deficiencies. It's 20 different components of the mitochondrial cocktail, activated vitamins, and it's made in the US by good manufacturing. And there's different flavors, and it's dose based on weight. Beyond that, CoQ is very important. It's important as an antioxidant, but CoQ is also important for energy metabolism, and it's not high enough in spectrum needs, so additional CoQ in ubiquinol form with an OL at the end is recommended. And then fish oil, the omega-3s, that's not it in either. And so in patients with neurodevelopmental disorders, I've always recommended additional CoQ in the ubiquinol form, omega-3s, and then a comprehensive mitochondrial cocktail, whether it's my own competitors, or in some cases we have to use individual components because somebody has a few people are sensitive to one or more of the components. And this is the websites if you want to learn more about spectrum needs or our own CoQ, neurogenomics program for peer-to-peer or direct telemedicine. And then if you're interested in coming to Pasadena, my private practice there. Thank you very much.
All right, so thank you so much to Dr. Boles for that wonderful presentation. There doesn't seem to be any questions, so we will end the webinar. And again, all of our attendees will be getting all of Dr. Boles' contact information, as well as any sort of the slides we used today, so you can reach out to him with any questions that you may have. So thank you so much for attending, everybody, and we hope to see you at the next virtual Grand Rounds. Bye.